My name is Chloe Berquist, and today we're going to be talking about ICU delirium. So when I think about ICU delirium, I think about an acute occurrence that happens in people that haven't drank enough water and are dehydrated, or maybe someone that hasn't gotten a lot of sleep. But I don't necessarily relate it to the hospital. But upon my research, I found that ICU delirium is very prevalent in hospitals across America and in the world. So what is delirium in the ICU? It's defined by the DSM, the Diagnostic Manual of Mental Disorders, as an inattention to surroundings and an inawareness of what's going on. This is an inability to direct, focus, sustain, and shift attention. This can be with what's the situation that the patient's there, why are they there. It can be with their disease process. It can be what time it is, what day it is, and even who they are. So why is this important? Well, it affects up to 80% of patients in the ICU and out of the ICU. And it is directly caused by being in the hospital. So as clinicians, we have to think of the things that we're doing that are causing harm to our patients, and delirium is a direct cause of what we as clinicians are doing in the hospital. Delirium is directly related to a hospital stay. So what causes ICU delirium? It's caused by improper sleep-wake cycles, sedation, and immobility are the big three. So when you're in the hospital, there's alarms going off, there's medications beeping, there's nurses and nurse assistants coming in and doctors every couple of hours to talk to you about your prognosis and your treatment plan. And every time someone comes in and disturbs you, especially overnight, then you're not getting good sleep. Oversedation, this is really big in the ICU. So when patients come back from surgeries or are having trouble sleeping, we often medicate them with medications such as propofol, Precedex, Ativan, or Versed. And all these medications help the patient to rest. However, when those aren't managed properly and patients don't get proper sedation and they're too sedated for too long, this can cause delirium. And thirdly is immobility. So in the ICU, when patients are really sick and they're not getting out of bed, they lose that touch with reality of putting their feet on the floor and walking around, and those sensors that relate that to your brain. And some patients are going to be in bed for a couple of weeks. So as healthcare providers, we have to think of ways that we can provide the most mobility safely for our patients. So those are some of the causes. Some of the effects. Well, a big one for the hospitals is that it increases the length of stay in the ICU and in the hospital overall. The longer length of stay means more money. It means poor prognosis, and that is something that is highly monitored by the hospitals. Another effect of it is increased mortality rates, and this is the big one that I didn't realize prior to this research, was that delirium is directly related to mortality rates. So according to the Critical Care Medicine and American Journal of Critical Care, patients with improper care of their delirium are going to be at an increased rate of 17% more likely to sustain delirium and have an average of 2.5 days longer of delirium than patients that are managed properly. In the American Journal of Respiratory and Critical Care Medicine, they found that in a study that every day a patient has delirium in the ICU, their mortality rate increases by 10%. So 1 day of delirium equals 10%, 2 days of delirium equals 20%, and so on. And that can easily add up over time. So it's really important to prevent and then also catch delirium earlier. So what are we doing about delirium? Well, in these journals, recent studies have shown this ABCDE bundle protocol is the best management for delirium. A is awakening. So awakening patients from sedation every single day if it can be done safely. B is breathing coordination. So this is not only waking them up from sedation, but managing their ventilator. So when patients are sedated and they are on a ventilator, it's important to take breaks from those to see if the patient can progress. So this is called an SAT, a spontaneous awakening trial, and an SBT, a spontaneous breathing trial. So the spontaneous breathing trial should occur within the time of the awakening trial to give the patient the best chance of progressing. 3 is the delirium monitoring and management. So this is assessing a patient's delirium status every single shift. This can be done with a CAM ICU test that can be used as save a heart is what can be used. So to perform this assessment, you will have the patient squeeze your hands every time the letter A is used in the acronym. And when you miss a certain number of variables, then you progress towards other steps to test if they're delirious. This is really important to assess them for delirium because if there's no assessment, then there's no way of measuring their state of delirium. And a lot of delirium goes unnoticed by improper assessments. So that's a really important one that we'll talk about a little more later. And then the third is early exercise and mobility. So this is doing passive range of motion and active range of motion every shift with your patient. It's getting PT and OT involved early so that they can help your patient move around. And even if they can't get out of the bed yet, even if they're on the ventilator, even if they're sedated, there are still things that healthcare providers can do to facilitate mobility. So due to this research, I found that at St. Helena Hospital needs a delirium and sedation management protocol. So in my policy, I outlined the purpose of the protocol, which is to implement best standards for our practice. This will keep our patients safe, and it will keep our patients without delirium and out of the ICU faster. And this turns to decreased mortality rates. In order for this to be a success, we have to have everyone working as a team. So these personnel responsible have to work together. And this is the nurses, this is the doctors, this is respiratory therapy, this is speech therapy, and occupational therapy, and physical therapy. All these branches of the healthcare system are needed to make this work. So in order to implement this, I will be presenting this to my manager and the hospital, and in turn it will go through corporate and some other processes in order to be implemented. But it is very important to have a policy to protect our patients. Some of the benefits of implementation of my policy is biggest and most important is decreased mortality rates. Secondly is a decreased length of stay in the ICU, which directly relates to healthier, happier patients and a decreased cost for the hospital. There will also be a decreased duration of mechanical ventilation. New studies are showing that the more often that you can wake your patient up and that you can do a breathing trial, the faster that they are likely to get off the ventilator. And lastly, it's an increased quality of life after the hospital. So, according to the American Journal of Critical Care, it is linked with decreased brain function over an amount of time. So this means that the patients can go home and experience a decreased brain function once they get home long term. Some of the limitations to this project was the number of resources that I could use. So this topic is fairly new in research, and some of the studies are just coming out with all these new details. So these limited number of resources do affect the way that this project was done. Another aspect was that I wasn't conducting my own research. I was doing a overview of the research that has been done. So I wasn't able to control all the aspects of the research. Some of the references I used, if you're interested in furthering your knowledge, are effectiveness and safety of the awareness of the ABCDE bundle protocol. And then a couple other journals, like the American Journal of Critical Care has really great information, as well as Critical Care Medicine. Well, thank you for listening to my project, and I hope that you learned something. Thank you.